Well, hi everyone. We are back for our SOF Health Deep Dive. Thank you for attending and being here with us tonight. I am the Executive Director of the Military Special Operations Family Collaborative, which, if you're not already aware, we are a public health initiative for the special operations community. So we look at how to put out effective health information, raise topics, to people that we need to engage on tough topics that are unique for our particular community. I am pleased to see we have a lot of familiar names and faces joining us. And if you're joining us for the first time, we're glad to have you. Please feel free to give us feedback at any time in the chat or follow it up with an email. This deep dive is a follow-on event from our July SOF Team Room, which is another event we do about 3 to 4 times a year with our partners. It's a virtual event that we co-host with the Global SOF Foundation to start community conversations on hot topics and get practical health resources into the community. In July, we talked about transition, building support network, and financial readiness, and a teaser on which we often call health sprints for the team room on chronic back pain. It's a huge topic with way too much to cover for the 20 minutes that those sprint conversations are. So we come back a month later and we host these deep dives to properly cover the topic and let you answer, and our experts answer and you ask the hard questions. So the SOF Team Room starts the conversation, but tonight's 2 hours on chronic back pain and special operations. We'll start off the evening with an overview on the full picture of back pain and special operations and the field in general, including the latest insights on treatment options that'll help you manage or treat your back pain. Then we'll start to talk about strategies that align surgery and care considerations for the your long-term life goals. For this is one of those topics where there's not always a fix to the problem. There are other strategies needed to manage pain or continue to receive care, and that is what our experts will dive into with you tonight. And then finally, we always touch on how your family should be involved in the decision to seek care and the pursuit of care, and ways that you can involve them in doing that. So it's a team effort. If you submitted a question ahead, we've worked to weave it into tonight's discussion, but we also have time for new questions during the Q&A sessions. Lindsay is in the chat along with Rochelle and David and the Return to Duty team, and we will make sure that your questions get answered tonight or followed up in an email afterward. You'll notice that this session is being recorded. You're welcome to keep your camera off to avoid being recorded if you prefer. This is an important topic for our community, so we push out the recording following the event in an email, and it's posted on a blog so that it can be used and watched by people afterward. Another thing you will notice, a couple anonymous poll questions pop up through the event. This helps us get to know the audience and your needs, and you'll see one pop up in just a second. And finally, one second, it popped up on my screen. So after you answer that poll question, you'll see several more throughout the night that help our experts see who's in the audience and sort of what your experience on the topic has been. We have 2 leaders from Return to Duty, which is a nonprofit dedicated to improving the landscape of care around back pain and treatment. Tonight, David Simmons and Rochelle Yusuf-Bekoff will lead our deep dive. Rochelle, I apologize if I fractured your name. You can make up for it tonight, and my apologies on that. But Rochelle and David are going to lead our experts and help pull questions and such out of the chat. Our experts tonight are Dr. Peter Durman, He's a minimally invasive and endoscopic spine surgeon at Texas Back Institute. He graduated with honors from Stanford University after completing a bachelor's of science in biological sciences and received his medical degree from the Perelman School of Medicine. Dr. Derman spends his time helping patients, conducting medical research and exploring ways to better medicine for future generations. So thank you, Dr. Derman, for being here with us tonight. Along with Dr. Derman is Dr. Ali Mazwala, who is a neurosurgeon with the Disc Sports and Spine Center and has performed the most artificial disc replacement procedures on the West Coast. His career began at Johns Hopkins University in Baltimore, where he graduated summa cum laude with a bachelor's degree in biomedical engineering, and then continued to medical school at the University of California, San Francisco. Dr. Mazwala helps patients understand the often complex problems that may be key to restoring function and improving the quality of life. Thank you, Dr. Mazwala, for being here with us tonight. We also have Dr. Lynn McGrath, who is a neurosurgeon specializing in minimally invasive and complex spine surgery at Weill Cornell Medicine. He's internationally renowned as an innovator working to develop diagnostic tools using artificial intelligence and is committed to utilizing his wide range of capabilities to tailor an approach uniquely suited to each patient. Welcome, Dr. McGrath. Without further ado, I am going to kick this deep dive off to David and Rochelle. They will give us an overview of common types of back injuries and causes of chronic back pain, and be here for all of your questions. So, David, would you please take the Zoom?
Thank you very much. I can say from the whole Return to Duty team that we're grateful, obviously, to be partnering with you guys and be back here again after last month's health sprint. It's been a wonderful build-up from last event to this one. A lot has even happened for us as a team with Return to Duty since then and now. And I just think it's wonderful that we kind of have this relaxed atmosphere for us to be able to have good conversation and a lot of folks that rally around a common cause. For those that, I just kind of a quick overview, some of you on here joining us are familiar with Return to Duty, maybe perhaps even were on the previous health sprint. Our mission essentially is being able to help facilitate spine care, if you will, commensurate to that of what, an entertainer, professional athlete would have available to them out there. For those of us that have come in from service, particularly in the Special Operations Forces or SOF community. I myself had a spine injury in Afghanistan in 2010. That was my first eye-opening experience to what is available and what is not available. Some of the disjointed issues sometimes that are challenging, not just in military medicine, but all across the board that lacks uniformity. But I didn't realize at the time essentially what that was doing was planting a seed for later on for our team at Return to Duty to go down the path, uniting and linking up with other like-hearted, like-minded people with tremendous expertise, like a lot of the surgeons that we have in our network, researchers and other folks from within the spine community. The way that we started out essentially was very informally, as many of you guys could imagine, particularly coming from the military community. We tend to just we see a problem. We're kind of wired to go, okay, well, how do we address this at the lowest level and make it as efficient as possible? Going to probably break some eggs along the way, but the thing is we'll work our way through it. In my case, I transitioned out of full-time government service. Was fortunate enough to be recruited in working as a clinical educator for an endoscopic spine company. And what that did was it started opening up my eyes to procedures that I knew for a fact were not being offered to myself, let alone fellow service members. And in that same course, I started being shoulder to shoulder and working with some phenomenal surgeons out there working on the spine. And very much in the same manner, that we take pride, kind of in the vetting and assessing, selecting of the people we work with in the special operations community or in the aviation community, very driven folks. You start to kind of naturally do that about who kind of people that you would hang out with, let alone in this case, we would allow to work on us or our loved ones. And so over time, informally, because I'm still serving with 20th Special Forces Group, now with the Human Performance Wellness Unit out of Florida. But over time, I found guys coming up going, hey, I got this going on with my back. I'm either avoiding care or I don't know where to go. And so in that case, I just, organically started pairing them up with people, said, hey, you should probably go talk to this person, whether it was Dr. Peter Derman at Texas Back or Dr. Lynn McGrath, as you see on your screen here. And then over time, I slowly found myself having, comrades, fellow special operations medics who were going, hey, I'm either retiring, like Nathan Alway on our screen here, or Jared Shuey, Troy NeQuinn, several other guys that we have on our team. And we started recruiting them over to come work in this space as being clinical educators and support people. And the word started getting around. Well, sooner or later, we basically realized it was a good opportunity for us to go ahead and start scaling that out and actually become formalized. And that's where Kevin Rash and Rochelle and Koshal, some phenomenal team members, have come on and basically helped a bunch of blue collar medics we take pride in being able to be honest brokers and really taking care of patients. In many instances, a bridge between that person out in the field with their sleeves rolled up and the next level of care. But we really needed some help when it comes to clinical research. Rochelle and Dr. Bott, Koshal Bott, have been phenomenal. Retired Major Kevin Rash from the pararescue wing in Florida, retired, served right along special operations units, all like-hearted people. And what we found was the ability to bring all of our gifts together in order to be able to come and start making a meaningful impact. When we saw friends of ours that were either really suffering and some even passing away due to bad medical care, substance abuse, alcohol abuse, a whole myriad of things. And so that is actually how you see before you the group of Return to Duty. We are just exceptionally fortunate that people like Dr. McGrath and the other surgeons that will be on this evening basically team up with us when they are very busy. They're very sought after. But the difference we like to say is that they look at us and they look at our patients, not just as another number. I know they do that with their own patients now, but in this case, what they actually do is they appreciate the military athlete in this case, the sacrifice, the burden that's put on them, and oftentimes the consequences if they don't seek care in a timely manner or if they go on long and don't get treated. So I hope that's helpful. As far as when it comes into unpackaging the ethos behind what we do, a big part of how Return to Duty works is because of the scale of our operation. We're an all-volunteer force, if you will, very much like the military service. We wanted to maintain a high focus on quality for each and every one of our patients. So to say, we didn't want to outrun our headlights. And so subsequently, we had to keep our patient population commensurate with what our capability and our size is. In some instances, we've actually had to put a waiting list because we have so many patients lining up now to come to us because we simply didn't want to give them poor care. We want to make sure it's commensurate with the staff that we have. And thankfully, because of Nate Alway and recruiting over some other fellow SOF medics now, more care case managers, if you will, we're going to be able to branch that out. Well, the way that we look at it is that essentially what we want to do is be able to have a active service member from within the SOF community be able to connect with us. And from there, we're able to start kind of getting assessment to say, hey, we want to at least be able to educate you on some of the different options that are out there and help throughout the entire process, be an advocate for you. But the other thing is to be able to help you to understand that you have multiple different treatment options that would be available to you for you to ultimately select and you to pair up with a respective surgeon, be it in our network or perhaps another one. But the big part is understanding in the care continuum, if you want to be an active person, either still in uniform, i.e. to return to duty, or at least retire and have the best quality of life, if you don't know what you don't know, you may very well end up having a procedure pushed on you, like a lot of people will, that ultimately could be career ending and be very detrimental in the long run. And we're not here to tell you what to get, We just want you to be educated when you're standing at that proverbial fork in the road, very much like I was when I had my spine injury, when Nate was, when Troy did, and several of our own staff who can relate, to let you know that you've got another teammate that's cut from the same cloth to be able to actually help you go down that road on that journey, not relying on Google, not relying on some fancy marketing, and basically being a force multiplier and not an adversary to the current military medical system. We recognize they have a very finite number of spine surgeons that were out the military. I think it's roughly like 18 or something. That's a loose number. I think that we were doing some research. But the big part is that if we can come alongside and if we start out for that very, high performing athlete within the military, and we can help to be able to be a force multiplier, one, we take care of our own people. Secondly, the other part is we can actually help with retention and the return on investment for all of that's been invested in these service members. So with that, Rochelle, I think I've consumed enough oxygen for everybody here. I will turn over to you, ma'am.
All right, I'm monitoring the channel. So my name is Rochelle. I've been with Return to Duty, I guess it's been maybe since the fall. Definitely since the beginning of this year. And since that time, it's been really amazing to see the growth and structure that has come into place. And just hearing the stories, helping the patients, it's been a real eye-opener to me, coming from the medical device industry, different various backgrounds, and being very heavily involved in clinical research. We become accustomed from the civilian side, because I haven't served, to what types of technologies and standard of care we receive with that in that world. And it was a real eye-opener to see the disparity of options for enlisted and veterans that have been, that have put their time in, and, just the lack of resources, lack of education on what the impact of those resources have been. It's been impactful. I'd like to actually take a moment to share a few of the other RTD leadership members on the team today. We have Kevin Rash, Nathan Alloway, Koshal Bhatt is on the call as well. And I just as a little bookmark, so Dr. Durman and Dr. Messiwala are in true surgeon fashion. They are on their way, but clinics, patients come first, as we all know. So right now we have Dr. McGrath from the surgeon side representing. So spotlight's on you, Dr. McGrath, for all of those clinical questions in the interim. But when they do arrive, I'll be sure to let them know that they have entered the chat. So maybe Kevin, Nate, would you like to kick things off with a little bit of your experience and your role with RTD?
Sure, I'll jump in. Kevin Rash here. I did 23 years active or reserve in the United States Air Force. The last 7 years, I picked up some work, got augmented a task force in 2015, working for ODA out of Kandahar, 19 Special Forces Group. Bubba's were running the AOB at that time, and then left active duty in the reserves, went to work in the PJ community, and then was an acquisitions guy for a while. And Dave and I worked together, and then I did some medical innovation, human performance innovation scouting with David and a couple other 18 series guys for a medical distributor, working in the SOF community, part of the interdisciplinary PODIF team, preservation of the force and family team. I worked directly with the strength and conditioning coaches, the psych doc, to make sure our team was ready to go as much as possible. And that's kind of what got me into this world. And Dave's one of my best friends. So I don't want to eat up any more time. I just really appreciate being here. Go ahead, Nate.
Yeah, Nate Alloway, did 23 years active duty. Most of that time was with the 1st Special Forces Group as an 18 Delta. I was a senior medic, company medic. And in my last job, I was the director NCOIC of the refresher committee at Fort Bragg for the Special Operations Medical Skill Sustainment course and the Special Forces Medical Sergeant Skill Sustainment course. Been with RTD about a year, the director of military affairs, and I handle all of the care coordinating team. Right now we're missing one member, but we have pretty much a member from each branch of the special operations groups that do all the care coordinating and help get the people from whatever unit it is, Rangers, SF, SEALs, help get them the best treatment they can possibly get outside of the stuff they're being told they need to have.
Awesome. Thanks, Nate. you know, a little thing that we were chatting about earlier too, were some of the recon work that you were doing. So I like to bookmark that for a little bit later. Kaushal, oh, and Messiwala has joined. Dr. Messiwala has joined. Kaushal, would you like to do a little intro with your RTD roles and experiences, and then we'll turn it over to the docs?
Yeah. Hi, guys. Kaushal Bhatt. I'm a non-practicing doctor out here in Los Angeles. I work with Dr. Mezawala in neurosurgery, and my role in RTD is to basically oversee all care for all the patients that are coming through, and working with everybody to make sure that it's delivered in a timely and effective manner. So yeah, that's pretty much it.
Thanks, Kaushal. So now that we have two of the surgeons on, maybe we can do a little intro with Dr. McGrath and then Dr. Messiwala.
Hey guys, how are y'all doing? Thanks for having me. I'm excited to talk with all of you about what I think is obviously a real pressing need in your community and in a lot of different communities. Actually, I think that there's a real lack of access and understanding around what goes into helping people with back pain, neck pain, numbness, weakness, those types of problems that might need spine surgery. It's not just this community that that struggles with getting access to good information. It's kind of a pervasive problem for most people. Actually, I just think that this community is a little bit more acute because of the lifestyle and the rigor of the day in day out work that you guys and gals do, and it just puts this into a little bit of a sharper focus. So anyway, I'm coming from Weill Cornell Medical Center up at Cornell in Manhattan, and I have a practice focused mainly on endoscopic spine surgery and minimally invasive spine surgery. Basically, just trying to find the least invasive way to treat whatever kind of a problem a particular patient has. Focusing on avoiding fusions, avoiding big surgeries in favor of doing smaller surgeries to get people back to their lives, their jobs, as quickly as possible, and especially in younger patients and athletic patients, doing non-destructive procedures where we're leaving as much of the normal healthy tissue in place as possible, so that we're not eroding their ability to go back to playing their sport, going back to their job, getting back to their life. And we're also not setting them up for a lifetime of more spine surgery or more spine problems, because we're doing as little damage to the spine as possible en route to providing a solution. So that's kind of the ethos of my practice. That's how I trained. It's how I met Dave and returned to duty, because I was looking for a better way to do fusion surgery through, in those cases that really do need it, through the tiniest little tube possible. And I found Dave as my proctor, teaching me how to use some of the gear that was cutting edge, and this sparked a conversation between the two of us, and that's what ended up leading to my involvement in this whole project. So we're all trying to get better all the time, and I think that's part of what leads us to want to work together, because we all have that mindset. So anyway, I'm here to talk about whatever it is you guys want to talk about. Another thing that drives me and wanting to be involved in return to duty in this community is seeing how wide the gap is between what it sounds like and what I have kind of seen, the access to care that the Special Forces community and their families have, compared to some of the other communities that I work with. So I'm a neurosurgeon. I work with NFL, not for spine surgery, but for head injuries for the New York Giants. And so I get to see just day in, day out what kind of care those guys get, and how everything happens within seconds of an injury being suspected. All of these services are basically on tap for these guys all the time. And it just struck me that that's exactly how it should be for Special Forces community. I mean, if not from a ethical standpoint, just from a economic efficiency standpoint. I mean, these guys, these communities are getting trained at the highest level. The investment is incredible. I would think that you'd want to protect that investment as best as possible. So I think it makes sense to be able to provide the same level of service in this community as it exists in other communities where there's kind of a similar level of training and investment that goes on to the practitioners. So anyway, that's my little spiel. I'll give up the mic, and Dr. Messwala, maybe you can talk a little bit.
Oh no, Dr. Messi.
All right, I
You got
unmuted.
it.
So Ali Messiwala, neurosurgeon here in Southern California. I operate in a place called Disc Sports and Spine, Newport Beach. We have offices elsewhere in Southern California as well. And so I really cover the full spectrum of neurosurgery, everything from minimally invasive spine to maximally invasive spine, and then endoscopic procedures, including skull base and vascular for the head. So my practice is really built on treating a lot of special operators and professional athletes. So as you've heard, I think from Dr. McGrath, there's a lot of stuff that exists for professional athletes in the world. They get care immediately. You guys don't have the same access to care, even though you guys are professional athletes of a different sort. And so spine surgery is actually incredibly simple. It's really just understanding the anatomy and then figuring out the best option for what your particular problem is, and developing a solution that makes sense. And so I think that a lot of the problems that you all deal with are in large part due to a lack of identification of the problem at hand, and then delays in treatment. And so if we can figure out a way to expedite that for you and get you what you need when you need it, then it allows you to get back to life unrestricted. And that's really the goal. So, whatever questions you have, hopefully we can answer them today, and touch on some of the new technologies that are out there that you may not have heard of, which are really delivering some interesting results in the world of spine surgery. I'm sure you guys have talked about taking discs out and replacing them and having fusions done, but there are even ways of regenerating the muscle in your back. So there are a lot of different options available now. So it just depends on what you have.
Excellent. Thank you, sir. Rochelle, I'm going to ask something just of Nate real quick.
Mhm.
One of the big things that the evolution of how we've gone as we have scaled up, and keep refining our processes in concert, in collaboration with Dr. Messiwala, Dr. McGrath, the entire Return to Duty surgeon network, is basically the revelation, something that Dr. Messiwala touched on, and that is that Nate can kind of give an account. One of the big challenges is that when a service member is let's say injured, we're not talking about like battlefield, but basically over time, it could be training, it could be whatever, but the bottom line is if you have a degenerative issue going on with the spine, but it reaches a point on one part, education of getting the patient population to better understand when they need to speak up versus being afraid of their career getting assassinated, whatever it may be. I know I can relate to that, and it gets into your decision matrix, if you will. And Nate, would you like to talk about as far as the timelines? Oftentimes it happens, like for a service member, when you have an injury, kind of sometimes antiquated, where it takes a long time before you actually maybe go get an MRI. And, whereas if you got the MRI, like Dr. Messiwala was saying, and you get that diagnostic to show that you need early intervention, and if you don't get it, by staying there, lagging and dragging on, that you end up having more of a deficit and eventually maybe a more heavily invasive or disruptive hardware-based procedure that you need that is career-ending. You want to share some of that we've talked about?
Yeah, absolutely. So what we find usually, unless it's an acute trauma issue with a spine or back injury for any one of the service members, they go to their primary care provider. They say, I have back pain. They ask some questions about, severity, loss of bowels, just the classic questions. If they don't say yes to those right away, they get put into a category if it's not a level 1 treatment. So then they get assigned a physical therapist, and it's never MRI or X-ray right away. They have to complete a physical therapy regimen in most cases. from the surveys we've done and the studies we've done, it's like, I'm going to say conservatively 75% of service members hide back injuries during their careers because they're afraid of the surgery, the healing process, what will happen to their careers. We have we've done surveys and polls for people, and that's pretty much what they say. So the people we've dealt with, they said like, hey, it's been 6 months. I did physical therapy. It didn't get better. In most cases, it got worse. And I go finally get an appointment with my primary care provider, and then they say, okay, let's get an x-ray. And they do an x-ray, and they say, oh, we don't see anything wrong in an x-ray. And they wait more time. Then they finally get an MRI. And then they find that in MRI, you have all of this damage done that we couldn't see through physical therapy or through the x-ray. And by this time, we've gone months, if not years, down the hole. So for me, it was 14 months from the time I got my MRI. And within 2 weeks, they were like, you need to have surgery. We have guys in the community, Special Forces. One of my buddies just texted me a couple of days ago. He was 2 years, and they finally had to do a 3-level fusion on his lumbar because the damage was so severe. It had been so long that the nerve was just so impinged, and there was so much damage. There's like the only thing we could do now is a fusion. If they had caught it months in advance, they might have done a more minimally invasive procedure, endoscopic procedure. But he had to do a posterior and anterior surgery, and he was 6 months in the healing process. Lots of drugs, a lot of self-medication. Couldn't really walk for 2 weeks. He said if he had known about the procedure, he would have not done it because the pain was worse for that 2 weeks than it was. Now he's 6 months past, so we're 2.5 years from injury, and he's like, I feel great now, but I really wish somebody was in my corner 2 years ago. And I was like, RTD just missed that one. We just stood up. So that's kind of what we're looking at. And it's not just back injuries that people have to deal with too. It's when I had my back injury in 2012, I was at nighttime halo jump, and I was 6 to 8 months from MRI and seeing a doctor. And I finally saw a doctor. He said, man, your back looks super good. And I was like, oh, really? I'm in a ton of pain all the time. He's like, well, if you were 150 years old and been in about 100 car accidents, like, what do you do for a living? He was a civilian doctor, and he could not believe that it had been 8 months since my injury that I had finally got to see a doctor. So that's kind of the hurdles that we see. And there's a lot of gatekeepers at these facilities who say, well, have you done physical therapy? And it's like, well, I don't need physical therapy. Like, physical therapy is not going to help. It's actually going to delay treatment, which will make things worse.
So I have a few questions too, some that were submitted prior to, the deep dive kickoff, and then a few things that are coming in that I might like, if the team's, ready, maybe I can interject a little bit. So one scenario, I'm going to put a scenario out there for you. So operator, massive trauma from a crash years ago, dealing with, had a fusion from L5 through S1, still dealing with a lot of weakness, tingling through the leg, groin. Epidural injections have been tried, TENS unit stretching. Some of those conservative care measures have been exhausted. For the docs, what would be the next appropriate step then? This has been a prior procedure that was done, a prior injury, but even after time has gone by, they're still suffering from this pain. Any of the docs, go for it. Just some initial thoughts. So how would they go? What would they look for with the provider? How would they go about seeing what options might still be available, even though they already had a prior fusion, is what we're looking to hear about.
So I guess I'll start. So I guess, the first thing is, it's hard to, without having seen this person, seen their films, right? It's almost impossible to tell you what the next steps are. But in general, right, if we were starting off with something like this in clinic, first things you want to do, aside from physical exam, on the imaging side, you want to know, has their fusion actually healed properly? Do they have a pseudoarthrosis or a non-union, meaning that the operation may have been done correctly, but the bone never healed, and that can lead to chronic pain. So they'll need some imaging studies, probably a CAT scan, some x-rays of their spine bending forward and back, and then probably an MRI as well. And then you just go through the process of seeing if anatomically things look okay or not. If it turns out that their fusion is well healed and there's really nothing else in the spine that's amenable to traditional surgery, then they might be a candidate for something like a spinal cord stimulator or something else, which is not going to rely on medications to treat them. If they have some sort of failure of the original surgery, then revision might be needed. That may solve the problem. So hard to say, but there's certainly a way to figure it out based on imaging and other things.
Awesome. Dr.
I think
McGrath?
one thing that I always recommend in these situations, I see a lot of patients where they have a surgery, they're not happy with the result for whatever reason, and then because they didn't have the result they expected, they come to me. I always say, go back to your original doctor and see what he thinks. You know, give him a chance or her a chance to kind of sort this out with you. If you don't like the direction that things are going, it always makes sense to have a second opinion. But you don't want to go out there and get 5 different opinions and just confuse the picture. I would say go back to the original surgeon, give them a chance to kind of work the process with you. And at the same time, don't be shy about getting a second opinion. No one's going to get offended that you went and got a second opinion. No one's going to hold it against you. And no surgeon is going to shy away from giving you a very blunt, honest assessment about whether or not the original surgery that you had was good or not. You know, we're all colleagues. There's not that many of us. A lot of us know each other. So we're always going to be, I think, forthright about the quality of work that one of our colleagues did, good or bad. And so I'd say go back to your original surgeon, work it out with them, but at the same time, work with an organization like Return to Duty to find someone to give you a second opinion as just a reality check, or just for the peace of mind at the very least, because a lot of the hard part of spine surgery, back pain, neck pain, sometimes it's just the uncertainty of what to do, what step to take, what person to trust. Frustration in dealing with spine surgery is the fact that you hear from so many family members and friends who mean really well these horror stories about their experiences with spine surgery, with back surgery. And it doesn't really need to be that way. And I think that there's a lot of gatekeeping that goes on because of the traditional outcomes from spine surgery and the way that it's viewed by, primary care docs, family members, friends, all well-meaning, but I think that leads to delays in care. It leads to a lot of patients that come to me after surgery and they say, man, I wish I had had surgery a long time ago. I've been living miserably for a long time because I was terrified because of the things that I'd heard. But, in that situation or in this situation, it helps to just find a trusted surgeon through a firm organization that you trust to give a second opinion, and that can take a lot of that angst out of the equation.
If I can share one
Sorry,
of the
Rochelle, I cut
benefits-
you off.
No, it was cutting out. I'm sorry on my side. Go ahead, David, because this might be a nice time to share that pearl that came up recently about those referrals.
Well, what I'll say real quickly is that the dynamic is that I know a lot of our patients oftentimes come back and say they appreciate right out the gate is the fact that having, if you will, their case being reviewed by so many surgeons that are supportive of the return to duty mission, by them being able to get these second opinions, multiple opinions, if you will, through us as a forum, if you will, like one of Nate's team members, our team members, but one of his case managers being able to have that particular patient's information now anonymized and being reviewed by Dr. Messiwala, Dr. McGrath, Dr. Derman, all these different ones, but having all of that experience, if you will, being able to look at it from the comfort of their home, from work, wherever it may be, reviewing it, and then being able to offer up different perspectives, if you will, I think we all agree that would be very hard for one patient on their own to typically try to go out and accomplish on their own. And I think that's one of the great, benefits of, patients that, we're able to assist, because we're able to offer them, in many instances, a type of concierge medicine, if you'll call it that, or concierge service that I think anyone on the planet, I know I certainly would want that. I would have wanted that back in my case. Now, Rochelle, you were saying as far as the referral earlier from
Yeah.
San Diego, or which one?
Well, so what I was alluding to was, for this case, right, this individual, this is a long time injury, some time has gone by, they're in the system, and it might be hard to go back to the original doctor, being in the system with who they were sent to, depending on the location. And then on top of that, as we've learned, as I've learned, I should say, some of the challenges of working through, because we're by with and through, working through the military channels to get those those external referrals for second opinion. So I wanted to kind of see if you could elaborate a little bit on that. It wasn't an
Sure.
insurance thing, but you know what I'm talking about. That'd be a nice little pearl to put in there.
Nate, you did a good job. I know we recently had a patient there in North Carolina that was running into some challenges. And thankfully, because of our teaming up with the SOCOM Care Coalition and the liaison, if you will, that you often work with there, that was able to help highlight the ability for a patient to get a second opinion, and not to deny them, if you will, the ability to get one. Would you want to share some of that for the group? Because I know that was kind of a new thing that's been empowering for us to kind of get to know that that's something to share in messaging for folks.
You're talking about strictly the North Carolina patient we were dealing with?
Mm-hmm.
Yeah, so I think I'm going to answer your question the right way, but I'm not sure. A lot of times we have patients who were seen a year ago, 2 years ago, and maybe they're gone to a different duty station, or that doctor has gone to a different duty station. And so what their continuity of care for that person no longer exists. So they're kind of like reinventing the wheel every time they go someplace. Sometimes we have surgeons who'd say, this is what you need. And we've had to actually talk to the patients and go like, you're allowed a second opinion. No matter what that person says, like legally, you're allowed a second opinion. If you're not getting that, or if a doctor's not willing to talk to you about a treatment option, or if you bring up concerns about it and the doctor's not really giving you the time of day, we can help you get to someone else who can give you a better understanding, or maybe a second opinion, or educate you more on what's available to you. So we've actually told this patient specifically, like, hey, go get a second opinion. We will try to facilitate that. And we were going to try to, the treatment, this surgeon, I've been doing this for 25 years. I do this procedure all the time. I'm super fast at it. I'm super good at it. And like, don't worry about it. It's going to be fine. Well, you're looking at a 26, 27-year-old service member who's being told like S1, L4, L5 fusion for something that he probably doesn't need a fusion for. So hopefully that's answering the question that you're asking about, if it comes down to, especially military members, like we can do IG complaints, and we can pull the trigger on some higher level people inside that support RTD that are still in the military side of things. So I think that's what you're asking.
Yeah, that's good. And I'll just say this real quick, and I'll give it back to you, Rochelle, is that I know we have a friend of ours who's on this call with us right now, another former Special Forces medic. When he, after he concluded his time, Purple Heart, had some injuries and different dynamics. He's provided some really intriguing testimony about he found himself working as a supporting rep for cases in the North Carolina area. And this kind of goes back to the part is that if the quote unquote mechanic that you're being referred to work on your car only knows how to do certain things, and maybe it's for only experience and knowledge, but maybe it's also out of convenience that this is what they're going to do for your automotive repair, in this case on your spine. But that you're going to get it whether you need it or not. And you could be a young, healthy individual who does not necessarily need a multi-level fusion, including screws rods and cages and everything else like that. We're not against those. But if a patient doesn't have a spine with instability, and this is once again where we always defer to the experts, the surgeons on our team. But as a whole, there are instances, sadly, where we have service members, like I was going to have done to me with my injury. Just my own stubbornness is what saved me. But basically, you'll have people who will get procedures because that's what's available, or you don't know any better. And so this is what's going to happen by being able to be, if you will, have these different eyes of surgeons who have a lot of different tools in their tool bag, and they've worked on these high performing athletes, whether it's Dr. Mesiwala with Red Bull athletes, SEALs out of Coronado, SF guys that have come in there, the folks that Dr. McGrath has worked on, the professional athletes, and so on and so forth. Like all the surgeons in our network that are used to working on this very specific type of demographic, let alone all their other patients. But what you want now, instead of just because you happen to be stationed in North Carolina or in Colorado, wherever it may be, it's like Forrest Gump. You may just get a random box of chocolates. The difference is what we're aiming to do is help provide a level of uniformity that you can make sure that all of the different care and treatment options are in fact actually available to you, not just simply because of where you're stationed at, that you just drew the short straw or something like that, but you're actually, because we're looking at you the same way of what we would want for us or our loved ones. And advocacy at the heart of the mission is to help make sure you're just not a victim of circumstance, if you will, or to basically what just happens to be available. So, Coach, I'll say you got your hand up, bud.
Sorry. Basically, what we're trying to do here is flip the civilian process around, right? Especially for special forces operators. So, what we can guarantee is that the patient is going to see the highest treatment rendering provider, which would be a spine surgeon, to determine what will get them back to doing what they do or what they've trained to do. I've talked to every single patient so far that has come through the RTD network, and their goals are very simple. It's either they want to go back into the field, or if they're retired, that they just want to be able to live a pain-free life, or at least be able to be good husbands or good fathers. And so I think those are very realistic possibilities, but by having every single one of those patients see the highest treatment rendering provider, they can determine what will get them back to that objectively. And so that's really what we're doing. Typically, you'd go into the whole conservative circle, kind of like what Nate was talking about, of physical therapy and pain management, et cetera. But we've seen it on the civilian side. It happens quite often that patients will get those therapies, but during that time, you're losing the health of the neurological structures, like the spinal nerves or the spinal cord, or in the case of the brain. And so you're looking at more complex issues down the line. And so by determining that a patient needs objective treatment, we're guaranteeing that there's preservation of their life or activity level. So
time is spine, the
Yeah.
longer a problem festers, the longer a nerve gets pinched, and the longer an injury is allowed to progress, the less likely it is to get better. So like what Koshal is saying is absolutely right. If you're looking at an entire country and how to provide healthcare effectively, back pain, neck pain, some of the most common complaints. So it makes sense to have these people jump through hoops to get care. But when you're talking about a very specialized group of people that are at very high risk of having, these types of injuries, just by the nature of the work that they do, it makes a lot more sense to get them right to the people that know exactly what kind of care that they need, and to be able to skip a lot of those intermediary steps. And that's a little bit about what we're trying to do. Another thing that I think David said that I just want to highlight, because it's one of the most profound things that RTD has been able to do, is assemble a team of surgeons that has the capability of providing every type of spine expertise that you could possibly think of. And that solves the major problem that every patient who's thinking about getting spine surgery has to confront, which is a little bit about what I was talking about before. How can I trust this person? Do I trust that they're not doing this out of greed? Do I trust that they're not doing this because it's the only thing that they know how to do? Is it that it's the only thing that they're even aware of, they're being available for the problem that I have? You get to kind of leapfrog that problem by having, 12 or 15 of the best spine surgeons in the country, all talking about your case, all picking it apart and deciding together with a consensus-driven kind of conversation what the best next steps for you are. So that really eliminates a lot of the other thing that I was talking about, which is really debilitating for people, which is the uncertainty. Do I trust the person I'm talking to? Do I ignore all of the warnings and the horror stories that my family and friends have told me? It really helps to get past that psychological and intellectual block when you know that your case has been talked about by 12 or 15 of the best surgeons in the country who represent the full spectrum of spine care and who aren't doing this out of greed and who aren't doing it because they don't know any better. All possible avenues are open to this group. And so you know that the answer that you're getting about what the next best step is driven solely by a conversation directed at finding whatever the absolute best next step for you actually is. So it's a really important point. David dropped that. I just wanted to make sure that we highlighted that, because that, I think, really is the core thing that makes this organization so unique and so powerful. It's honestly something I wish existed for all of my patients, but especially the ones I care about the most, my family and my friends, because it's a really powerful mechanism.
Thank you for that, Dr. McGrath. Thinking about some of the stuff you said, I say, why don't we take it back a little bit about some of the questions that have come in, and concentrating back on some of the patient focus, exactly taking that theme of what you said of what RTD is built upon, and kind of leaving the floor open for some of the questions that from the pre-submission. So I just want to read a couple of them off, and then I'm going to keep an eye for Dr. Derman as well. So right now, Dr. McGrath, you're in the hot seat until Dr. Mesiwala comes back. So I hope you're ready. Kind of thinking about what you had mentioned, that continuum of care, the process of care. Maybe we can start first with a few questions about conservative care. When they're first injured, they're first starting to come down with symptoms, first coming down with, back pain, whether they have some numbness through their arm or, shooting pain down their leg. Can you walk them through some of those conservative care treatments that they should try leading up to really getting that more surgical assessment? So maybe acupuncture, PT. What are some of your thoughts on that? We'll start soft and then we'll go deep.
Hey,
yeah, no, definitely.
Rochelle and Dr. McGrath and Mesiwala, one question. So we get a lot of we hear a lot of stories of service members and family members that are hesitant to seek care because they've put off pain for so long, or they're really good at managing it. So what are some of the symptoms that they would experience that they should trigger you to say, hey, maybe I should go look into these and get care? And I don't know if is there an ability to kind of put it on a spectrum of like these type of symptoms would sort of put you in like this level of care response or research or intervention, and then these type would be more concerning and maybe be worth jumping through the hoops to push for an MRI or something of that sort.
I'll just answer very simply, and Kaushal, Rochelle, David, you guys, Ali, can add to it. But I tell patients, listen, pain is pain. Pain's not dangerous necessarily. It can drain your energy and really erode your quality of life. But pain is not necessarily dangerous. When you start feeling numbness, tingling, weakness, that means that your nerve has stopped just being irritated and now it's getting injured. And that to me is a different category of problem. So if someone has numbness, tingling, weakness, I say, okay, time to stop fooling around and let's figure out what's going on and figure out why this nerve is experiencing an injury. Preferably, you have an MRI already. Because for me to, in good faith, tell someone that has really severe pain, let's try acupuncture, let's try, massage, let's do some core strengthening, muscle relaxants, whatever. I want to know that there isn't something that is mechanical and, unstable that is not going to be served by any of those things. So, I like to have an MRI really to be able to tell a patient for sure that they would benefit from conservative management. But if you're not in that kind of a situation, you can't get that at the drop of a hat. I think RTD can help with that, but really you should think of numbness, tingling, weakness as red flags that trigger you to push for a higher level of care.
I think just to add on to that, I mean, all the patients that we've dealt with are experiencing pain or symptoms that are actually impacting what we call our activities of daily living. And so, it's the inability for them to work out, to be able to hike with a 120-pound pack on their back, their inability to jump out of an airplane and land without pain. And then we're seeing people that that are recently retired and just cannot pick up their baby or dance with their wife. And you're telling me that the people that are protecting this country cannot even get an MRI to assess what's happened after they've either had hundreds of jumps or have been blown up by an IED in Afghanistan or Iraq or in Africa or somewhere else. It's pretty absurd. We saw a 40-year-old Green Beret that was blown up by an IED in Iraq, and he had a very simple request. He said, "Doc, I want to be able to play with my kids." He's 40, and his MRI looks like that of a spine of like a 60, 70-year-old person.
Now,
I mean, it's
well,
and we're seeing two issues as well, right? So he's been getting MRIs every year since he came back, but no one wants to do anything, and they want to wait until he develops weakness in his legs. And then there are other service members that can't even get an X-ray or an MRI. But the delay in care is going to now increase the chance that whatever would be offered as a modern solution will turn into something much larger.
Well, and one question we hear a lot, specifically in the special operations community, is, our service members are really, really, really good at compartmentalizing pain and pushing through, especially if there's a goal at the other end of that. And so one experience they have in seeking care is you might go to a civilian provider or even a conventional military medicine doctor who hasn't seen a lot of special operators. They're not used to seeing guys that have jumped out of planes like 100 times or more, or doing some of the other things SOF do. And, the first thing out of their mouth might be, "Why don't you stop jumping out of planes?" Like, they literally may not understand the drive to serve and the requirement that comes with the job. So that's something we often see as a barrier to seeking care for active duty service members, is the disconnect between providers and understanding why would you go to that extent to serve. Like, that's an extreme dedication to country, which is
Right.
something we're super proud of in SOF. And then so that's one challenge. And then even the service member knowing how to navigate that interaction with a provider can be awkward. We hear this from spouses a lot too, who are with their service members seeking care. So I'm curious, like, if you get that interaction from a provider in the military or out, when should you keep pushing to say, "Hey, can you get to the base of this pain? Like, I'm not having pain or tingling, but I throw my back out picking up paper once every quarter." Like, what would you tell a service member like that?
So
First of all, I would say they're not unique. I work in Manhattan, and billionaires with every type of access that you can imagine still have a terrible time navigating the system and finding out what's best for them. So it's frustrating. It's a universal problem. So just something to be aware of. But you know, what Kaushal said, I thought he put it very elegantly. When the pain starts to impact your quality of life, when it starts to interfere with whatever you think of as your activities of daily living, you know, walking, it could be something as simple as just going for a walk with your partner, taking out the trash, playing on the floor with your kids. It could be, that's what some people want to be able to do. It could be playing your sport at a high level, or jumping out of an airplane pain-free, or at least, you know, with as little pain as it takes to get the job done. You know, I think as soon as you realize that you're not happy with the way things are going, then you need to start pushing more for yourself, because ultimately there are solutions to these problems. They're not like all that mysterious. It seems like that way sometimes, but ultimately there are solutions. And sometimes that solution is time and patience. But if it is that, you need to know it, and you need to be directed that way. So as soon as you start to feel frustrated about the level of pain that you have and the way that it's interfering with your life, you need to be a little bit more vocal about getting the answers that you want. And if you're not getting them, vocal about finding a new pathway to go down with somebody else who can get you those answers.
Yeah, I mean, the nice part is that here at DISC, and what Dr. McGrath is doing, and what the other physicians that are in RTD do, is that they're used to dealing with patients that want to return to very active and very physically demanding lifestyles. You know, we've worked with professional sports teams like Dr. McGrath has, and we're used to, I mean, based off of our conversations here, it's kind of like what he was saying. If you have patients that have trained for years, like SOF members have, they just want to go back and do what they do. And every single one of them is like, yeah, I can't deadlift 200 something pounds. And, you know, we don't get to see that on a daily basis with every single one of our patients, you know. But the nice part is knowing that all the patients that we see through the RTD network, and the patients that we've seen already with the military and special forces, have the mindset that they want to go back to doing that. And we appreciate that. We understand that. And every single doctor in this group appreciates that. So we do know how to relate to them, and we treat them with the objectivity to get them back to that point, because that is ingrained in their mind and soul to go back to be able to do that. So yeah, that's kind of the objective that we run with.
I'd like to answer the question that Brian shared there. I like that. It has actually, and because this is perfectly timed with this, and what we're finding is that you're touching on something I think that I didn't really realize, and I think many of our team, that, you know, coming from the patient population, you know it, but you don't really comprehend it fully until you can look back on it in the rearview mirror. And that is that the culture, if you will, that we all, while you're doing this, whether you're a pro athlete or amateur athlete, or, you know, in our community, let's just say, the culture is one of a mindset that if you went out and, like, you know, I broke my leg, you know, or something like that, well, that's kind of self-limiting. The interesting part is it's very subjective around the spine, because we are almost accustomed to pushing through medicating, you know, give me the Motrin, give me the Toradol, give me the whatever else. I stayed loaded on Toradol for another month, still running out on mission, didn't realize how bad it was for my liver. But it's one of those things, is that it's a mindset. Part of what we're doing is, on one part, there's that, is understanding that it's okay to say, hey, there's something not right about this, because back pain is synonymous with carrying heavy rucks and jumping out of planes and different operations you do and everything else like that. And so everybody has it. Well, on the other hand, you have the part where you're trying to kind of change that aspect of knowing when it's okay to say, maybe I need to get this checked out, because you've got, you know, tingling, pain, all these different things going on. You've got incontinence, bladder control, foot drop, whatever it may be. But on the other part of it is that it's a two-pronged thing. You also have confidence that if I do speak up, what's going to happen to me is, because of the precedent set before me, I hear all these horror stories of guys getting quote unquote butchered, getting fusions they don't need, careers ended, whatever it may be, all the narcotics or, pain management they're doing to deal with the surgery after they get it done. And if it doesn't go well and everything else. So there's two parts. And I appreciate once again the question because what we were realizing is that through this journey, the hope is where we want to go with this is ultimately get to where the patients have confidence that they can come to a trusted entity to be able to know that it's safe, to be able to get second opinions, that these are people who understand you and you will get treatment options and you will help be able to frame out your problem, if you will, and knowing what's normal, what's not normal, and what your options are. And then the second part is once they know that my career is not necessarily going to get assassinated simply because I try to seek out help and the culture starts to change because the conversation around it starts to change, that perhaps people, instead of going, oh, well, it's just back pain, screw it, load me up on whatever, I want to continue mission, I'm going to get after it. Instead, you go, all right, well, you'll know whether a person's, where you're quitting, you're malingering or whatever's happened. But usually our patient population, you don't have that problem. The cool part is you get to the point where like, hey, I got this going on. And I trust that if I go seek out and I want to get on this early so that I don't basically put a tourniquet around a part of my neural structures and starts withering and dying off because I've either got bone or I've got some other soft tissue that's crushing it. The nice thing is you start to be able to help where people can start going in and being able to say, hey, I'm going to treat this like other parts of my body that I would jump on it a lot faster.
That's actually a really good segue. And I would just like to say, Dr. German and Dr. Mesiwala and Dr. McGrath are all here now. So we have the full surgeon guest speaker. So welcome. With what you were sharing, Dave, I think that's a really good segue for one of the questions that was submitted from the pre-registration. And, we're from our seat, we're kind of deep in it, right? So we kind of know what some of the options are, but taking a step back, maybe the doctors can speak a little bit to what resources are available besides fusion, what types of procedures are really out there in the market right now with the technologies for the people that might not be as in-depthly, as educated on some of the newer the tech that's out there. Please go ahead.
That's a great question. Hello, everyone. Sorry I was a little late. Things just went a little longer in the OR today than expected, but I'm glad to be here. Just cut me off if I start saying stuff that's already been said, but I'll give you kind of to answer your question, how do you avoid fusion? I think that the least invasive surgery is no surgery. And so my goal for all of my patients is to help them avoid an operation if at all possible. And I think about spine care in really three phases. So, phase one, as long as there's none of those red flags, like the weakness, the bladder bowel stuff, which are actually like the less common things. But, back pain, neck pain, sciatica, pain down the arm, numbness, tingling, those kind of things, as long as they're not in the general area, those can be very distressing and very painful, but are not necessarily urgent, dangerous type things. And so if possible, I'd like to start people with physical therapy type exercise type program, anti-inflammatory, non-narcotic type medications. That's phase one. Phase two are like injection-based treatments. So there are a variety of different kinds of injections. There's epidural injections. There's something called rhizotomies or radiofrequency ablations that can be very good for back pain. And that's kind of phase two. And then phase three, only if those first two phases are not successful, is where you start to think about surgery. Now, that doesn't mean that just because you didn't get the relief you needed with phase 1 and 2, that surgery is a good idea. So, we can only fix certain things, and it's very important as a surgeon to know what you're able to fix and what you're not able to fix. But the things that we're most able to fix are really nerve compression and spinal instability and spinal deformity and trauma, obviously, as well. But a lot of what we're treating on like a chronic basis and most successfully is nerve compression. And so really what you're looking at from a surgical perspective, if you have nerve compression causing either symptoms down your arm or symptoms down your leg, is what is the least invasive way possible to take the pressure off that nerve? And that starts with things like decompressions, which means just a clean out type procedure. There's a variety of different ways to do a decompression. Dr. McGrath and I do a lot of endoscopic surgery, which is the least invasive way of doing so. I did 4 of them today. So I operated on 4 patients today who had severe sciatica, some of them weakness in their arms and their legs, and every single one of them is going to be sleeping in their bed tonight, not taking narcotic pain medications. And what an endoscope is it's a camera. So just like you can get your knee scoped or your shoulder scoped, instead of opening up the spine in order to peer down with your eyeballs to take the pressure off the nerves, you can make a little 8mm incision, place a camera down, which doesn't destroy or disrupt the soft tissues around the spine, see within the spine on a big high definition camera, and clean out around the nerves. And in many cases, you can do a decompression, so just a clean out procedure, where traditionally you would need something like a fusion type operation because we're not destabilizing that patient's spine. So that's like really my favorite kind of category. Another category of surgeries are disc replacement type surgeries. So a disc replacement involves removing the disc itself and placing a spacer in that moves. And so in some cases, you can't just do a decompression, and a disc replacement is necessary. But the beauty of that is, even though you're removing the disc and placing the implant you are maintaining motion, and that preserves or is better able to preserve the levels above and below. Because the problem with fusion is if you fuse a level, you sacrifice motion at that level, and therefore you're going to make up for it above and below. And the concern is over time that could result in the need for additional fusion or other type operations. So by preserving motion either with an isolated minimally invasive decompression or with a disc replacement, it decreases the chance of needing future surgeries. However, and I'll stop talking soon, if there are circumstances where a fusion is necessary. And so, every once in a while I do fusions also. And that's cases where there's true instability, there's a fracture, there's deformity, substantial curvature of the spine that is creating the problem, or the nerve compression is due to the fact that the bones are in the wrong spot. And in those cases, the fundamental problem is the bones are in the wrong spot or they're not stable, and you need them placed back where they belong and stabilized. And that's what a fusion operation is. However, not all fusions are made the same, and there certainly are minimally invasive ways to accomplish these goals. And I won't talk forever because I can, but that's kind of my overall treatment algorithm for spine surgery. It took me 27 years of school to learn that, and I distilled it to you hopefully in 5 minutes.
Awesome. That was great, Dr. German. We really appreciate that. Go ahead. You had something?
Well, I was going to ask really quick. He mentioned all of the patients he had today didn't go home. They all slept in their beds and they didn't go home on much medication. So what are your 10 cents on pain management and how people should approach it in a non-surgical need or a surgical need?
Very good question. My goal is to minimize narcotic pain medications. And so I essentially never prescribe them except for immediately post-operative for my kind of larger operations. It is not, unfortunately, a good long-term treatment option typically for pain. And because the problem is you get more and more accustomed to those medications, and then you need more and more of those medications, and it's kind of a vicious cycle. So really the goal would be to minimize or completely eliminate narcotics from the treatment of chronic conditions.
But I love it because pain management is a huge thing in our community, and especially in the SOF community where our service members have been through so much. There is a lot of wear and tear on a lot. They often walk out with multiple chronic conditions and a whole bucket full of medicine, which partners of ours at Task Force Dagger Foundation and Hunter 7 often talk about the over medication and the many exposures our service members have. And so we did get a lot of questions in advance that ranged everything from physical therapy, steroid shots, mindfulness techniques, and even thoughts on using psychedelics to manage pain when it came to back pain. And I didn't know if you have thoughts on any of those. Also really quick, Lindsay is going to drop a quick poll for people so that you guys can kind of see how many people in the audience we have seeking care on back pain.
So I was just going to kind of loop back to the question that came through related to sleep. I don't know if Dr. McGrath or Derman have any tips, tricks, doctors' perspectives on when your pain starts to interfere with your ability to get a good night's sleep.
I saw that question. I don't have any great resources off the top of my head for how to direct self-care pre-op, but I will say that one of the most common things that people tell me after surgery is how life-changing it is to be able to get a good night's sleep and not be woken up by pain. A lot of the times patients with back problems have a very hard time sleeping because in many cases laying flat or standing up straight pinches the nerves more than like leaning forward or sitting down. So actually sleep is one of the things that can trigger some of the worst pains for a lot of patients. So one of the things that I hear the most is just how good it is to be able to get a full night's sleep or a better night's sleep after surgery. So that could be a real benefit. But I think Kaushal is going to work on getting something for us. And I don't know if Ali or Peter has any tips or tricks in this regard.
Yeah, one related question that I get frequently is, what pillow should I be sleeping on? What mattress should I be using? And in medical school, we didn't have like the pillow mattress section where we, the KaLea Tempur-Pedic 34A or whatever like that.
We should have.
We should have, but there's no such thing. So actually, I got asked that question so many times that I actually looked in the literature to see if there is in it. And I wrote a blog post about it. So like, if I don't have the direct link, but we can share it. But if you just Google my name, Peter Derman, and sleep, I think it's the first thing that comes up. And I basically summarize the existing, albeit not great literature on pillows and mattresses. And long story short, it's a lot about trial and error. It depends a little bit on the position that you sleep in. So if you're a stomach sleeper, for instance, you're going to want a firmer mattress and a flatter pillow, because really what you want your spine is to be neutral. If you're a back sleeper, you'll probably want like a medium height pillow. And if you're a side sleeper, you want like a taller pillow because you want it to support your neck so it's in a neutral place. As far as like firmness of beds go, it really depends on your body size, basically. So like a larger person will need a firmer mattress because they're going to cause it to sink in more. Whereas a lighter person won't push down on the mattress as much, so they can have a softer mattress. So medium firm overall seems to be kind of the average. However, the giant caveat there is it really depends on your sleeping position and your size. And so, a lot of it is kind of trying out what works the best for you.
Yeah, so I'll jump in. So, I mean, obviously I do the surgeries too, but I'm also a patient. So I've had back surgery. I had it done, almost 14 years now. And so the same questions are asked, I think, of all of us. But one thing that is true is that, what works for one person doesn't necessarily work for another. And so, what I found is that, and I own no shares in the company, nor do I get any financial benefit from it. But, things like sleep number beds, we have, the ability to adjust the firmness of the bed from, super soft to maximally firm. And then you can adjust the position, seem to work very well for patients because it gives them a lot of flexibility. And just to kind of go back to, surgical options. So, I agree with everything that's been said. I mean, certainly no surgery is better than some surgery if you can avoid it. And, if you go from minimally invasive to maximally invasive, it's typically a decompression, through motion preservation all the way to a fusion. But the other things that we haven't talked about are these other regenerative therapies. And so, there are people that have significant back pain and don't have substantial abnormalities with their discs or joints. And so that's an area where multifidus dysfunction can be an issue. And there's new devices that are on the market that actually regenerate muscle. So it's not a spinal cord stimulator. You're not covering up pain. So it works through a very different mechanism. And then there are patients who require, other pain interventions that are surgical, be it spinal cord stimulators or other things that may give them, stimulation of peripheral nerves or their spinal cord to deliver pain relief. And so I think there's a huge spectrum of treatments, and it really comes down to being evaluated in a comprehensive way where you go through the entire process and rule out structural abnormalities from, bone, disc, nerve, joints, muscles, and so on, and then figure out what the structural abnormality is, if there is one, which is a source of pain. And then if you can target those things, it's great. The other issue, which I think is unique to special operators, is that oftentimes the decompressive operations that we perform, be it endoscopic or minimally invasive open ones, aren't necessarily going to work for people who can't afford to take time off and can't afford to change what they do for a living. And so, the way that we treat certain professional athletes, individual sports are different than the way we treat others. So, the way that I handle a professional baseball player is different than the way I handle a football player. And you can do certain things in one that you can't do in another. Because for example, if you do a fusion in an MLB player, they can't go back and pitch, they can't go back and hit. It's very different than if you do a fusion in an NFL athlete, they can go back and play. And so, disc replacements are unique. And so those are things that have historically not been done across all sports, but we have a variety of professional athletes who've had them done, and they've chosen not to disclose it for the time being. But I'm sure that'll come out. And then you'll find that disc replacements in, a variety of contact sports also work very well. With special operators, we've done multi-level disc replacements. They've done very well. The incidence of recurrent injury requiring additional surgery in special operators is high when you tend to do microdiscectomies and laminectomies and things. So it's just, there's a lot to think about. And so I think depending upon the type of sport you play, or if your sport is special operator, it may dictate, one thing versus another, but having all these options available to you are really key.
I think to kind of give you some props here, from when we were at the Special Operations Medical Association Scientific Assembly. Now it's a mouthful, but I see Ricky on here, who's also there, one of the chair for the Brain and Spine Committee. But when you got up and spoke on that, and you presented your presentation, that is, it was interesting after you concluded, because you presented a lot of different cases of whether it was SEALs or guys from interagency and some other different places like that. And because you were able to draw the parallel, like each of you as surgeons, and just kind of giving examples, like with some of your professional athletes, whether they're pro surfers, but whatever repetitive motion, understanding kind of a la carte how to select your treatment options, understanding this, let's call it a unique patient population, and the expectation to get up and get back into it very quickly, so to say, and all the considerations prior to the surgery, after the surgery, but even picking out whether it's medical technology that you utilize for it, and having that in the full picture as you go ahead and try to implement that. And it was curious because I remember specifically a Secretary of Defense rep stood up and wanted to talk with you, and then a command surgeon from one of the special mission units, wanted to pull you aside and talk. And the big question was, like we all know here, our priority first and foremost is helping the patient immediately. Whichever of these patients that come to us, however we can help them to maximize their return to duty, quality of life, all those things. The secondary component, and this is where giving a plug to Rochelle and Koshal, is basically them being able to help, where our goal is being able to tie into the long-term research component on this, so that we're being able to take across disciplines, whether it's the civilian, amateur pro athlete, or in this case, the quote unquote tactical athlete, so that we have understanding. I see many friends on this call with us that come across the medical device industry, and big champions and advocates themselves as athletes, and wanting to help people of all walks of life across the spectrum be able to get back and get going, because we know an active person is more inclined to be a healthy person and be better for everybody all around. And so an interesting part, I think, that you touch on there is seeing how it resonates, let's just say within the military medical community, is understanding that there still is a lot of work that can and will be done in order for us to help better understand basically, as we have each patient, how we continue to keep refining those treatment options for them and how to get them back with the expectations they have.
Well, I was wondering, as you guys were talking and listening, especially to Dr. Mazwala and about, even the difference of professional athletes, which as an active person, but ignorant of the demand of those sports from a medical perspective, it wouldn't occur to me that the consequence would be so notable in the type of intervention. So in special operations, this seems like an area where we really would need an active duty service member needs to go into seeking care and expertise with a little bit of a different mindset than maybe a veteran population, which we did have several ask the difference between how to seek care as an active duty service member and how to seek care as a veteran. And I think, with return to duty kind of helping be an intermediary, maybe for them it's more about when to seek care, how long to wait if you're active duty, or as a veteran, some questions they maybe would come ready for before they had like a comprehensive assessment.
Yeah, so one of the things that comes up, and I think you make a great point, is the difference between an active duty service member and someone who's retired, right? So one of the first questions that we ask is, are you intending to go back to work? And if so, what does that work entail? And so I know I presented this at the SOMA meeting, and that was, we had this guy who's an interagency operator who was very clear that he needed an operation done, or whatever was going to be done, need to be done in such a way that when he left the clinic, he could be gone for a year and a half or however long his duty service was going to be, and then he'd show up whenever he was done, right? And as long as he was good to go, and I wouldn't ask him exactly what he was going to do, but he was released to do whatever he needed to do, he would be cool with it, right? And that's very different than telling someone that, hey, we're going to do this endoscopic discectomy on you, and you're going to be out for 6 to 12 weeks. And by the way, I really don't want you to put on a 120-pound pack and jump out of an airplane, because your chance of having a recurrence are fairly high. Those are very different conversations. And I bring that up because for those of us who, prior to doing this type of work, the weekend warrior is a very different patient population than someone that has a $150 million contract. And, they're intending to go back to work, and, playing on Sunday for an NFL team is a very different type of interaction than someone that may just sit out the season because they can't play for their local league. And so I bring this up because special operators are exactly the same, right? Instead of getting paid $150 million, they're using equipment that, is valued at millions of dollars, and the country has spent millions of dollars investing, resources in them to make them who they are. And so we're asking you guys to do something in an unrestricted way. And so oftentimes medical care doesn't always meet with those expectations. So I think it's really, really, really important to understand the difference between the civilian population and the special operator, which is really just a professional athlete in a different sense.
Do you find that the SOF service members that you've worked with, do their families play a unique role in engaging in the conversation of the trade-off of how to seek care, and maybe even the consequences of what they choose to do to manage the outcome and control?
Yeah, it's a great question. I think that it really depends on the individuals, right? So there are a lot of special operators who aren't married, don't have families. And those individuals tend to be pretty aggressive at wanting to get back and doing what they need to do, especially when they're younger. I have a patient who is a contractor for an interagency department. And he came to clinic with his 2 young sons who would not leave his side, and his wife. And he was very clear that he could not afford an intervention that would not allow him to go back to work. And his wife was very supportive of it. And even though we talked about doing something, he wasn't willing to take any risk or any time off because he needed to get back to do what he was doing because that was important to his family. And so then you have the flip side, which are spouses who really don't want their spouse to go back to work in that line of work and are pushing for something very different. And so the family dynamics can be very interesting, and there can be a tremendous push and pull. And all we can do is make our recommendations and offer what we think is best. But ultimately, you're right. I mean, what the family unit wants may be very different than what the individual wants. And that's a very difficult thing to tease out sometimes in clinic. And that's really something that's probably best left for the home discussions. So hopefully when the patient decides to have something done, everyone's supportive of what they're doing and why they're doing it.
It sounds like that's a unique role that return to duty plays in the way you guys work between doctors and reporting, connecting people to care and care options. It's helping navigate.
I see a lot of times that patients very eager to get surgery. Family is not at all behind the patient getting a surgery because everyone's getting opinions from all of their family and friends, and most of it is negative. And but they're not experiencing what the patient is feeling, so there's often a disconnect. And yeah, I think trusted advisors like RTD can help bridge the gap between what the family's hearing and what the patient's experiencing, so everyone feels like they know what the best next thing to do is.
KaLea, I'll give you, and I may have shared this earlier on when we first met, but just for the audience, this is a salute to Dr. Derman, but one of our early patients on service member, my wife's unit in the Air Force. And I just basically, because I had, met and we had become close friends in his journey and getting his expertise in endoscopy and everything else like that, like many of all the surgeons on here and throughout our network of people that we trust, that we would, go to or our family members. Well, in this case, my wife became aware of a service member that basically a single mother, teenage boy, needed her flight status and everything to be able to stay. Well, she was being advised that she needed multi-level fusion, cervical fusion, and by a local surgeon. And anyways, what she was concerned about is that was going to, in this case, impact, her status and everything else like that. And she wanted to promote all these different things because now it's not just her, but it's her son and all these things that are impact. We're talking about the whole picture here. And so basically she got connected with me, and I just basically reached out to Dr. Derman and I said, hey, here's the dynamic, what's going on, and would you be willing to, at least if she wanted to come see you? So basically fast forward, the dynamic is that what I really appreciated, and each one of the surgeons do this, and he did this, and it's exactly what Dr. Messiwala said. You start with the picture of the patient and you actually ask them, what do you want to achieve? Let's start understanding, gathering information, all these different things, the full picture of where you are both physically as well as mentally. What are your goals? What are you trying to achieve? And as this patient said, she goes, it was the first time anyone in the medical treatment, we hear this with a lot of our patients, shocker, but someone actually asked me those questions and then started to formulate those factoring in to the treatment plan in order to be able to do this. And I'm very happy to say, this service member did not get medically boarded out. She was able to resume PT and everything else, career and so on and so forth. But we see that over and over again now. This is happening. And it comes down to the simple fundamental thing is that having advocacy, having surgeons, this team that actually cares enough to want to understand the whole picture rather than just pulling whatever easy lever that it is. You're just another commodity going down the conveyor belt. But each one of us would hope that that's what's being done for us because we have to live with whatever happens.
And importantly, that patient, not only did she not need a multi-level fusion of her neck, she didn't need any operation at all.
Yeah. Yep.
And so I'm glad that you introduced us and we helped her avoid, what would have been a life-altering operation and not for the positive. So, spine surgery can be a great thing, but it's only for certain things that it really helps people. And if they don't have those things, then oftentimes there's non-surgical things that can be more beneficial.
Exactly. And we had a patient that came through out of the North Carolina area. And thank once again, Koshal Messi help, Dr. Messiwala helped with this. But this patient locally was being referred to a multi-level fusion, and he's more likely a candidate for the multifidus muscle stimulator, the reactivate system that he referenced. And once again, here's a situation of a patient in the absence of advocacy may very well have just marched right into this and got this, these options. And so it simply comes down to them being empowered through education, a trusted form of advocacy, and then being able to have experts who truly have all the tools in the tool bag, if you will, across the spectrum, but also having experience to understand people like them as patients and what the outcomes look like. Very, very outcomes-based medicine.
I think I have an answer to your question too. Oh, there's another survey. I'll look at it later. So we find too that service members going to our primary care provider is, it's just a doctor that is seeing people at a clinic. And we found in the past couple of months that getting a patient active duty or even retirees at sometimes, they come in, they just need education. They need a care coordinator that knows what's going on. They need to get part of their branch specific care coordination team. So like whatever it is in USOCOM, and to have somebody at their unit that can speak for them and then can give them like our number, our information, and then we can give them the education. Because we've had a lot of patients who are like, my doctor's saying this and they want me to do this. And it's like, okay, come talk to us, get a care coordinator, get your own unit representative also, so everybody's in the loop, get your chain of command involved, and then we can kind of cut out that primary care provider who's not educated themselves on what needs to happen and how it needs to happen, and then we can get them in touch with our doctors. Then gives them a different, complete different idea. I'll share a quick story. I want to say it was $60,000, but I'm pretty sure we have one of our patients was about to drop $60,000 on stem cell because people told him that's what he needed. Not people in our community and that, but before he came to us, he was like, I am ready in 7 days to fly to another location, another country to do this procedure because all my friends who are now doctors from Google said like, this is the procedure I need. And I was like, whoa, slow down. Like, let's get you some education. Let's talk about these things. And he's actually being seen by one of the doctors in RTD, and it's ended up that's not what he needed. So a lot of it is just education, getting them the right team. And then on the retiree side, it's still having them come to us because those same options aren't there for them. I can't call a group surgeon or somebody at Regiment or wherever they came from and say, this is what this guy needs. Like, can you please just write him a referral to this doctor? He's 20 minutes from you. And so it's harder on the retiree side, but we're still with geographic locations and who we know and what care providers or care coordinators they have from USOCOM. We're able to take phone calls, not we, but directly me, and say like, okay, where's this person at? What do they have? What do they want? What are their expectations? It's a question. It's like pain. Somebody brought up pain earlier. I try not to ask the pain question to operators. I go, okay, on a scale of 1 to 10, what's your pain right now? And they'll be like 6. Okay, like what's the worst pain you've ever felt? This pain right here. Okay, well, this is a 10 then. Like, don't just make an arbitrary number of like what pain is. And that helps a lot of times when I'm talking on the phone. It's like, what's the worst pain you ever felt? Like, I was on an IED blast and I had this much pain. Okay, so that's your 10 based off that. What's this? And maybe conservative therapy, we can get you to a 3 right now until we can get you further on down the road. So hopefully that answers the question about like how we're handling taking in patients on both the active duty side and the retiree side.
I love that how you address pain question, because that comes up across the board with SOF operators. We have had some providers say, sometimes they will get to where they're over reporting pain, but especially for active duty and a majority of SOF, it's under reporting pain, just like that. And it can lead to challenges with them seeking care and actually communicating how it's impacting their day-to-day life to providers. I did want to double back on what you mentioned. You mentioned stem cells and then Dr. Stepanenko in the chat asked about exosome therapy. Dr. Stepanenko, if I said that, one of you guys know what how to say that better than I just did. But could you elaborate and share your opinion on these and like where they may be relevant or why they may not be relevant? Because oftentimes Dr. Google runs away with any community, but sometimes ours too. So if you have an opinion on those or have any literature on them, that'd be awesome as well.
I hate to be Debbie Downer, but there is not strong literature yet on the use of stem cells or exosomes for the use of spinal pathologies. These are not FDA approved treatments, in large part because there's not strong enough literature to suggest using them. I think that the future probably is largely regenerative. I hope that 50 years from now we look back and we're intervening earlier and helping to grow discs back and things like that. But the current state of affairs is not that. I think that likely there's relatively little risk of undergoing these procedures, although anytime you inject anything into a disc, for instance, there is a risk of infection, and that's not negligible. I think the main risk is wasting a lot of money, and because these treatments are not FDA approved, they're not covered by insurance, and many times patients are asked to shell out $5,000, $10,000 for a service that really is not grounded in any sort of strong literature or kind of treatment history. And so, I think the major risk is really losing a lot of money and not getting really anything to gain for it. So I personally would not, unless you're exorbitantly wealthy and it doesn't matter if you have $10,000 less dollars, then I think that this is probably not where you want to spend your money.
I think a lot of times people are desperate for a solution, and so they're willing to try just about anything. And I also think that sometimes there's this perception that rich people that are connected know about things that the rest of us don't know about, and they want to try those things. They want to fly to that clinic in Germany or Brazil and get an injection that's not available to everybody. The reality is, if that stuff really worked, it would be much easier to get, and it would be much closer to FDA approval, and it'd be accepted on a much wider basis. There is some evidence of some of this stuff working, and so I think that depending on your unique situation, it might be worth exploring with somebody who does a lot of it. But just beware that it's certainly not the standard of care. And if it really worked in a reliable way on a widespread basis, then it would be the standard of care. So just buyer beware, as Peter said.
I actually looked this morning because I was curious. I saw that question about exosomes, and I actually looked in the literature, and there is some maybe promising, very basic science studies like petri dishes and cells and maybe rats, but I couldn't find really any human data on the use of exosomes for the use of spinal treatment. And maybe it exists, but certainly wasn't easy to find, and it's certainly not pervasive like the other kind of things that we routinely use to help people feel better.
That sounds like it's a solid 20 plus years away from being a legitimate method that maybe someone should consider.
Do you guys have any? I have a real passion for like acupuncture. I think I've had a lot of patients and family members, including my two little brothers, who are both former athletes, and they're my little brothers, so I think they're idiots most of the time, but I don't think that they're completely crazy. And they both came to me and said that they got acupuncture and that it worked spectacularly well for them. So I'm a real advocate for that. Do you guys have anything along those lines that you've seen kind of punch above its weight, or that you really advocate for strongly that might be flying under the radar a little bit?
If I could just share real quick, I know with my injury, like I said, back in 2010, Doc Morey was a battalion surgeon in country at the time there out of Bagram. And he had taken it up some years, prior on this case. He was always, ever expanding out, the tools in his toolkit like all of you guys do. And interestingly enough, when I got brought back towards the end of the tour and getting ready to head out, because I was, stayed loaded up on Toradol, like I said, had to keep running out on mission. In this case, he actually started utilizing acupuncture on me, both, the needle type and everything else like that, as well as, I thought it was kind of wazoo crazy stuff, putting the things in my ear and everything else. And all I got to tell you is the proof's in the pudding. It was helping. I mean, for whatever reason, the spasms that I was having that otherwise were not getting relief. I mean, I was like a walking turd. I couldn't turn my head, at all, and gave relief. And interestingly enough, I know that, TRICARE, if you were to look it up, does not cover it like a lot of other different things, chiropractic and stuff out there. But Doc Morey actually started teaching that to a lot of the SF medics when we would go and do our interdisciplinary non-trauma module lanes and stuff like that. And I'll just have to say is that I think there's a lot more room for it to be open, if you will, in terms of treatment options to be offered up, if you will, that may at least be worth the consideration.
Yeah. I know other doctors, battalion surgeons at the group level. And I believe actually in one of our deep dives a year ago, Dr. Kaufman, who was a military doctor for a long time and worked at NICO for a while, was a big fan of acupuncture and taught it to doctors and medics as well. And
yeah, there's pretty good evidence for acupuncture, Western evidence that it is beneficial. Another kind of Eastern treatment that has good Western evidence or pretty solid Western evidence is turmeric supplementation as a natural anti-inflammatory. And so for my patients who don't want to be on, Toradol or Advil or Motrin all the time, taking a gram a day of turmeric, which is more than you could just sprinkle on your food. You have to get it as a supplement, and you have to have it with black pepper extract. That helps you absorb it. But if you take that every morning, I've had patients that have good response to back pain and neck pain with turmeric supplementation, and that too is supported by the literature.
If somebody were to try that, Dr. German, could you go to the pharmacy and buy a gram of turmeric with black pepper? Or
Yeah.
That's exactly what they would look for. And do you happen to have a literature that we could share in the blog post following this on that?
I can get it for you.
Okay.
But go to like either the supplement stores or even some of the big warehouse stores. They have it there. It comes in gram tablets with the black pepper extract in it already. It's the common way of being taken. And you just take that, once a day, basically.
That I know is something that's been emerging with rheumatic disease and managing pain as well. Dr. Stepanenko asked about red light therapy modalities. Any perspective on those?
I'm not personally aware of any literature on it.
No, neither am I, but worth looking into if he's heard of it.
Guys, I just want to apologize for all the questions and kind of formally introduce myself over here, the little, keyboard ninja way in the background. But Army primary care doc for 8 years and integrated modalities, lifestyle, nutrition, incorporating that into care, anti-inflammatory strategies, anything that works, because these people were suffering. And I was working here at Fort Bragg, North Carolina, a lot of soft veteran community. So like MSK injuries and orthopedic pain was clear to, name of the game here. And the only way I could get them to talk about lifestyle or diet at all was if I could give them some breath of fresh air with pain. And that's where that battlefield acupuncture was a bit of a game changer for me, because I could change the conversation after a night or two of good sleep and a little bit of pain control. And, that was while en route to next step. And yeah, I had to jump through the damn hoops that you're talking about, imaging series of modalities. Did they do physical therapy? But, subjective reports of red flag signs are subjective reports of red flag signs. All right. So, are you experiencing something that will get you in conversation and in front of the doc that can make a better, diagnosis? Tell me right now and we'll make it so. I would do a warm handoff as well and be like, hey, here's the real deal. But still, get through the system, however possible, assigning nurse case managers, managing their expectations that, hey, here's what we're saying is going on. And here's the reality of what we're trying to accomplish. And here's why the hell I'm talking about these things over here. Here's what I'm going to do in the meantime. So just wanted to apologize for all the questions, but I really appreciate your perspective, and the discussion has been phenomenal. Thank you. Appreciate your time.
Don't apologize for questions, because everybody has them if they're not asking them.
Oh, great questions. And it sounds like you're doing God's work. And I'm wondering if you're taking any new patients outside the military, because it sounds like you're doing an awesome job.
Thanks. I appreciate it. I'm working on it. Yeah. I separated in December, so I created some freedom of movement, but I'm figuring out how to bring awareness or wisdom back to the community. That's why I'm thinking in terms of outward education or awareness of self-care, first steps, do this at home, advocate for yourself, know these things and make better decisions. That's where military, MSOFC has been phenomenal. Like, we're all figuring out how do we get the right information in front of the right people so they make better decisions. Increased awareness starts with education. So that's what's up. All right. Thanks, guys.
That's awesome. Thank you.
Awesome.
Yeah. Well, let me double check some of the questions we had come in. I guess to double back on some of these, some people asked, is it better to get treatment before or after retirement? And when the treatment options potentially worse than the problem itself, that I know we covered early on. If there's pain, seek an opinion and seek care. But just make sure to describe what your goals are and be open with the provider.
I said earlier, just to hit on that point again, one of the most common refrains after people get surgery is that they wish they had gotten it sooner, because they wait years and years and years. Everything, all the messaging is wait as long as you can, avoid it. They go through it, they're home the same day or the next day. Their life is completely different than it was before. And so I'd say, as long as you have good mentorship and counseling from someone who can help you navigate the military side of things, there's no better time to start down the path of treatment than right now. So
one type of care that is brought up all the time but hasn't come up tonight for back pain or joint pain in other places, chiropractic care. What is the state of the research on chiropractic care, and where does it fit in with chronic back pain?
I have I think there's probably a lot of opinions on this. I have the opinion that I think chiropractic care is great. It's worked for me personally. I was a rower for 8 years, destroyed my back and my neck. And it was actually a chiropractor that got me back into fighting shape after having to go through a whole ordeal. That said, now that I'm on the other side of this, I see some complications come out of chiropractic practices that I think push the envelope a little bit too much. I'm all in favor of a chiropractor acting as kind of like a shepherd, organizing a bunch of non-operative conservative modalities. I really don't like manipulation, spinal manipulation in the lower back, but certainly not in the neck. I've actually operated on 2 patients that had strokes because they had, neck manipulation done, tore arteries in their neck. So I think that is kind of an inherently unsafe thing. I don't think it's great for the discs, the joints, the nerves, the blood vessels in the neck. But that said, I think there are a lot of things that chiropractors offer outside of that can be really useful. So you just have to go into that. I think knowing what you want and knowing what you will and won't, get talked into at a given practice. So another one of those things where it's buyer beware. I'm all for them. I have great relationships with a lot of them. They've helped me personally a lot. but you have to know the good and the bad parts of the practices and find someone that you have a good relationship with.
And I'll echo that. I think that just like there's a spectrum, not all doctors are the same, don't always have kind of the same philosophies in treatments and patient first kind of care. You know, there's a spectrum of chiropractors, some that are very good and patients swear by them and they keep them functional and comfortable. And then you see kind of these horror stories. I see patients come in and they put a mortgage out on their house or they've sold their car because a chiropractor told them they need, you know, to buy a set of 62 manipulations at $10,000 in order to help them feel better. And there's just no evidence that that's the case. And just like I wouldn't want my patient to spend $10,000 on stem cells that are not well established, I wouldn't want them to spend $10,000 to have their bodies stretched in some sort of machine. So, you know, I think it's just finding the right person that has your interests at heart and not shelling out a bunch of cash for something that is not well established in the literature.
It is actually time for us to wrap up at 9. I was double checking to see if we missed any questions that were submitted.
I think we covered the bigger sweeps, but there might be some individual ones that we can get out there in more detail.
Always happy to continue the dialogue with people offline. You know, if people want to reach out, ask specific questions, happy to be available anytime.
That is fantastic. We will make sure to offer that in the blog and in the replays. After our deep dives, we always send out an email with the recordings. A lot of people register and they've got kids' games and their other places and they watch it later. And so anything that came up tonight where you all think it would be great to attach any research, the state of the research, even if it's a podcast on some of these therapies, treatment options, or articles on how to sleep better, things like that, we can attach it to the blog and those go out with the email to everyone who registered. And sometimes people ask for it later too. One thing, I do see something here on steroid shots and therapy to manage pain. Any take on that when it comes to back pain? I'm guessing they've decided against surgery if that's the case. I don't know. Correct me if I'm wrong on that. They weren't clear in their question. They did ask about the role of steroid shots to manage chronic back pain.
So I think this was touched on earlier. I mean, for a lot of patients, that forms one of the earlier treatment modalities before you get to surgery. So steroid shots can be epidural steroids, they can be point injections, they can be facet injections. So as mentioned earlier, it's just part of the treatment spectrum. So normally well before surgery.
Okay. And if it's not working, keep talking to your doctor.
Yeah, and there'd be roles for other things afterwards and eventually surgery. In some cases, people get injections after surgery too. So just depends on what it's being done for.
Okay, very good. Well, before we close up, anyone else have any final comments or questions or things that you hope people see in the replay or hear in the chat tonight?
I'd just say thank you once again. I know that our mission continues and value allowing us to be able to kind of have fellowship and join in on this multi and two-way conversations, if you will. It's wonderful because we know, just like the last time, I'm sure many great things will be growing forth out of this as well. So for each of the surgeons on here, there's other ones that are in our network that aren't on the call right now. The nice thing is that even that much more will get greater reach to patients, and I'm sure we'll continue to keep building on this together.
Yeah, thank you guys for being here. Return to Duty for bringing in the experts tonight. Dr. Mazzuala, Dr. Durman, Dr. McGrath, Koji, and everyone else from the team. You guys, thank you for being here, sharing your expertise, your information. We couldn't do the deep dives without you, and it's these forums that just let people ask questions. especially when it comes to such a unique lifestyle, like so many in special operations have. This is a safe forum for that, and we're super grateful for your time and expertise applying that to this issue on chronic back pain. If anyone still has any questions you'd like to ask the experts, please email them to us at home@msofc.org. Or you can reach out to the Return to Duty team. If you have questions about how to get plugged in with them, or anything on this topic, please feel free to reach out to either of our teams to help plug into care and get your questions answered. There is a link that I believe is dropped in the chat that will have some survey questions, so you can give us your feedback about tonight, ways we could improve the deep dives, or maybe there's a topic that you would like us to take on next. If there's something you would like to see covered, please let us know. And it may be the next deep dive. So stay tuned for more information, and watch out for the blog and the email. And thank you for your time tonight. We value you and are grateful to have you in our community. Thank you.